Hi everyone, this is Mr Neel Raithatha here, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with bilateral fully blocked earwax, and we're just starting off in their left ear, and as you can see the entrance of this left ear is virtually shut, so they've got a collapsed ear canal entrance, and in order to gain access we're having to open and widen the ear canal entrance in order to insert the microsuction probe, the Zollner suction probe, and we're actually using the endoscope, so the tip of the endoscope, the distal end, so the part furthest away from us, not only to stretch the ear open but then use it as a doorstop to keep it ajar, which then allows us to freely insert the suction probe. You can see the wax is quite matted here and it's adhered to the canal walls. There's a lot of keratin as well, dead skin around the edge. And I'm just slowly bringing this out of the entrance. And when you have matted wax and dead skin like this, it can make it a bit more difficult because the suction grip is not as powerful. So I've just put some olive oil spray actually. Now this is olive oil that's medical grade olive oil. It's not the stuff that we use to cook, so it's not extra virgin olive oil. And I prefer using the spray because I think it evenly coats and ejects within the ear canal. Sometimes with a dropper bottle you can get lumps here and there, but it doesn't evenly coat. So you can see that oil really helped remove that piece of wax and skin. Again, I'm stretching open the ear. So I would say half the occlusion's been cleared. There's just a bit of dry wax and matted skin a bit deeper. I'm just using the fine end suction probe there. So at this stage the patient's hearing's been restored. However, I'm just going to continue and try to remove some of this dead skin that's lining the base of the ear canal. So it's just got a bit blurry just because the hairs are there. Let's just move the endoscope slightly further away. I think I've had to use some forceps as well. Now, with regards to the collapsed ear canal entrance, people can develop a collapsed ear canal for several reasons. It may well be the patient's slightly elderly, so as we get older the cartilage weakens and then gravity takes over. So it's similar to the tip of the nose. The outer third of the ear canal, the cartilaginous portion, is made up of cartilage. The lower third of the nose is actually, so the lower 2/3 of the nose is made up of cartilage. The upper third is made up of bone. And the cartilage over time can weaken just with age, and then gravity can cause it to droop if you were at the tip of your nose, and it can also cause the ear canal entrance to collapse. Someone who's developed, or prone should I say, to chronic ear infections, they can, over time, it can weaken their cartilage. And so I'm just using some forceps. It's very difficult getting the forceps in just because of the narrow entrance. Now I didn't remove every little last speck of dead skin. Just trying to remove as much as I can as safely as possible. I don't want to cause any trauma to the ear canal or any discomfort to the patient. So you can see I'm just going in, so the top jaw is at 9 o'clock and the bottom jaw is at 3 o'clock, so a different angle. Again, it's just really difficult getting access. But I think I'm just going to mop all that up around the edge and then that'll be job done. So I'm just using the fine end suction probe. And I've just gone to the back part of the ear canal. As you can see the skin here, I'm just peeling it away. Now, what can be done about a collapsed ear canal? Do individuals need surgery? Typically no. You'd be surprised that so a collapsed ear canal very rarely causes a hearing loss, unless it's completely sealed, so there's no air at all or sound waves going in. But in this case, there's a slight opening there. And quite often when you mention it to patients, they're not aware, other than the earwax, they're not aware that their hearing's been affected by the collapsed ear canal. So very rarely do patients with a collapsed ear canal need surgery to correct it. Sometimes it can be difficult for patients who wear hearing aids. So you can see I've cleaned the ear. There's a few hairs there. I'm just going to leave that though. The ear canal's narrow, as I mentioned, and trying to get access with that, I'll have to remove that with forceps, and I'm going to find it quite difficult getting deep in there. Just at the lateral part of the base of the ear canal now. It is glossy dead skin. I'm just trying to peel that away. So sometimes patients with a collapsed ear canal, it's difficult for them to wear hearing aids because it's difficult to insert the hearing aid into the ear. But there's always a way we do manage. We can do open jaw impression, so we can get the patient to open their jaw slightly, and that widens the ear canal naturally. And then we can take an ear impression of their ear whilst their jaws are jarred. And the good thing, fortunately, about the outer third of the ear, because it's cartilaginous, it is slightly flexible and malleable. So if you manage just to push the hearing aid through the narrow aperture, then it can the cartilage itself kind of mould itself around the hearing aid. So there's always a way. Now this is the patient's right ear. Similarly to the left, just put some olive oil in there. You can see the plug of wax is enveloped by dead skin, and all this skin has become sticky and glossy in appearance. This ear canal is a bit wider, it's not as narrow. So, but similarly, I'm using the endoscope to stretch the ear ajar. So I'm inserting the endoscope and I'm stretching the ear over to the left just to widen the entrance. And then we're using the endoscope as a doorstop. So not only are we stretching the ear open, but we're keeping it ajar. That then enables me to insert the instrument. So this is a bit more medially impacted. So I'm just using the suction push, and I detach it from the front part of the ear canal and now from the roof of the ear canal. You can see the hairs there. Now, the reason for the hairs is that the patient does trim their tragal hairs. So the tragus is the tiny small flap of cartilage right near the entrance of the ear, so it's triangle in shape. And with elderly men, for example, are more prone to getting hairs there. And of course you can trim them if you wish, but I always recommend just put a bit of cotton wool just at the entrance, don't shove it in your ear, just to create a seal. So when you do go and trim your tragal hairs or any hairs around the ear itself, they don't fly into the ear, and the cotton wool prevents that from happening. And then once they've finished trimming the hairs, they can of course remove the cotton wool. And that's just a good tip for anyone. So again, you can see the eardrum at the distance, it's nice and healthy. I'm just gonna, this is kind of a blind spot where we're working at. With other visualization techniques, we probably miss this, you wouldn't see it. And that isn't going to cause the patient a problem. No, of course not, it's not blocking their ear. But whilst I'm here, we're on the cartilaginous portion, so we can put a bit of pressure. So I'm just mopping that up. And you can see the anatomy of the ear canal. So it veers off to the left, and then it veers back to the right. So that cartilage in the ear to the right, that's the second bend. So just there on the right. And once you get past the second bend, the ear canal straightens. Well, I hope you enjoyed that video, guys, and you're all taking care of yourselves and keeping well. And remember, be nice and be kind to each other. Thank you. Bye.